Good afternoon, everyone. Uh, First of all, this is a sponsorship by AstraZeneca, and the slides have been provided by them. So that's a disclaimer. So the topic is unleashing the controversy: LHRH agonist versus LHRH antagonists. So many of the points have been already delved on in detail by Amit Joshi sir and Kumar Prabha sir during their talks and panel discussion. So that's made my job easier. So I'll be focusing on the important points. So we know that it is quite common. We have been discussing since the morning, and it can be of different stages: the high risk localized, locally advanced, metastatic, hormone sensitive, and castration resistant. And all the first three categories, the role of hormone androgen deprivation is definitely there. And even in castration, we continue the androgen deprivation. So we know the different type of LHRH agonists are leuprolide, triptorelin, goserelin, and LHRH antagonists are degalics. And we know that basically the agonist they initially bind to the LHRH receptor, and this leads to increased production of LHRH, which leads to negative downregulation, and further the androgen production stopped. Whereas in the case of LHRH antagonist, they bind to the LHRH receptor, and this leads to no downward stimulation and stopping of androgen production. So, as we have discussed since morning, that the time to reach the castrate level is different with the agonist and antagonist. So for the agonist, it's around 3 to 4 weeks, and antagonist is quite common, quite less, 96 hours. So when we need a quick response, and when we cannot afford a flare, in that case, antagonist is used compared to agonist. And the rate of PSA failure is also lower with antagonist compared to agonist. And other things also we'll discuss subsequently. And the most important point of which is that local injection reaction is less with agonist, only about 1% compared to 40% with the antagonist. And the cardiovascular complications are around similar. And the administration schedule is for agonist, we have both monthly and 3 month schedules. But for antagonist, we have only monthly schedules. So as we have been discussing that for patients with severe symptoms or with impending emergencies like spinal cord compression or with severe bone pain or obstructive symptoms, in that case, we require antagonists. So the common formulations are the goserelin 3.6 mg and the 10.8 mg depot formulations, which are given subcutaneous, and the Degalis 240 mg, which is given monthly. And no dose adjustment is needed for mild to moderate hepatic impairment with goserelin, unlike Degalis. So the three important settings in which this drug can be used are the localized prostate cancer, the locally advanced, and the metastatic prostate cancer. So we'll discuss all the three settings separately. First, coming to localized prostate cancer, we will discuss a few trials. So in the EOTC 22860 trial, in this trial, the patients with newly diagnosed prostate cancer were randomized to receive radiotherapy alone or with adjuvant goserelin 3.6 mg, and the primary endpoint was clinical DFS. And we can see that the 10-year disease-free survival is around significantly improved. The HR is 0.42, so from 22.7 to 47.7%, that much is the benefit. And the prostate cancer mortality also significantly reduced by around 1/3. And in the overall survival, there is a 40% improvement in the 10-year overall survival with goserelin adjuvant versus RT alone. In another trial, DART 105 Nycod study, high-dose RT with a short or long-term goserelin was compared. So, neoadjuvant goserelin was given, followed by radiotherapy only, or also adjuvant goserelin for 24 months. Again, the primary endpoint was biochemical disease-free survival. So again, we can see that the 5-year DFS is 90% with the long-term goserelin compared to only 81% with the short-term, only 4 months of goserelin. So again, this shows the benefit of goserelin given for a long time as adjuvant, around 2 years, compared to radiotherapy alone in this setting. And also 5-year survival, also you can see that there is a strong benefit, a 9% extra benefit compared to only short-term goserelin, and up to 95% 5-year OS. with the addition of gosling for 2 years. Then coming to the second setting of the locally advanced prostate cancer. So again, in this, the neoadjuvant gosling was given along with the androgen blockade of flutamide, and this was followed by radiotherapy and gosling. So again, in this, there were three settings: no neoadjuvant, only for 3 months and for 6 months. And again, the primary endpoints was time to local failure and prostate cancer specific death. So you can see that the disease specific mortality of compared was at 10 years 23.3% versus 35.6% in the gosling arm compared to the arterial arm. Again, this was statistically significant, and there was significant disease specific mortality in the RTOG 8610 trial. Again, in the TROG 9601 trial, again, there is a 51% reduction in the risk of prostate cancer specific mortality over 10 years versus RT alone. So you can see that the maximum benefit is at the 6-month arm, and the HR of around is 0.49 in that arm, and the p-value is highly significant. Again, in the survival rates of these trials, we can see that at the 10 years, the estimated OS rates were 43% in the gosling arm compared to 33% only in the arterial arm. And again, in the all-cause mortality, again, we can see that is significantly improved. In the 6-month arm, the HR is 0.63 as was shown. Again, following the adjuvant gosling in the following radical prostatectomy, again, we have the AFU16 trial. In this, patients with rising PSA 6 months or later following radical prostatectomy, they were given 6 months of gosling plus radiotherapy or radiotherapy alone. Again, the primary endpoint was progression-free survival. And you can see that the 10-year PFS was 64% in the gosling arm compared to 49% in the radiotherapy alone arm, which means a 46% reduction in the risk of progression. So you can see that the compare in all the subgroups, it is favoring the addition of gosling. So across all the different variable factors, it is favoring the addition of gosling as adjuvant. So coming to the metastatic setting, so we know that metastatic the prostate cancer is highly dependent, and as we have seen in the discussion by Prabhash sir and Anuj sir, so the two options are arcrectomy versus the LHRH agonist or antagonist. So initially it was compared to arcrectomy, and we can see that the benefit in the mean time to response and the median time to treatment failure with this, and the median OS also, you can see that median OS was definitely better with gosling compared to OS. So it is as effective as surgical castration in clinical outcomes, and with the antagonist and analog, there are different profiles regarding the time of time which patient results in castration levels. So the recommendation for ADT across disease states is consistent between guidelines. So you can see that between NCC and the European Association of Urology, ASCO and ASCO, all of them recommend in the high risk localized disease the ADT of around 1.5 to 3 years. EAU is around 2 to 3 years. So basically around 2 to 3 years is the recommended duration of adjuvant ADT, which can be gosling as shown in these trials, which has a benefit. And in the locally advanced disease also, around 2 to 3 years is the recommendation. And metastatic hormone disease, we all know that it should be given continuously by any of the methods which have been discussed previously. So we already discussed the agonist and antagonist. So coming to gosling, it is available as 3.6 mg and 10.8 mg implant depot formulation in a pre-filled syringe for subcutaneous injection with a 16 gauge or 14 gauge needle, and it has a single-step delivery system and minimal administration time advantages. And the implant helps in gradual release of the medicine over intermittent period, and this prevents needle stick injury. Moreover, since it is not a liquid injection, there is no need to displace air bubbles. And coming to Degrelix, the main drawbacks are it is given every 28 days. The main drawbacks are the more frequent days every monthly compared to 3 monthly with gosling, the longer time required for injection reconstitution, and the inconvenience of 2 injections during treatment initiation, because we gave a loading dose of 240, so 2 doses of 120 have to be given. again, the efficacy evaluation of the both. So the various trials have been compared. So the main points of the efficacy comparison that all the direct trials were comparison were open label, and the overall treatment population showed a comparable reduction in PSA level in testosterone suppression as well as in prostate volume reduction. And the patients on Degrelix, as expected, showed a more rapid decline in the testosterone PSA levels. However, higher number of gosling treated individuals achieved reduction in testosterone levels. Uh, and Degrees could not prove non-inferiority to gosling for the co-primary endpoints. And most of these RCTs compared 1 monthly formulation of both drugs compared to the 3 months, which is the available with gosling. So one more strategy is the change from gonadotropin releasing hormone antagonist to GHRH agonist therapy. So initially, as the patient need a rapid reduction symptoms, or they might be at risk of progression. So at that time, you can start with the antagonist, and then because both cost and administration of monthly is the issue, so we can shift to the agonist after giving a 2 or 3 doses of antagonist. So this strategy has also been practiced, and you can see that the OS was nearly superior in the change group compared to the continued group. So the faster testosterone response with LH antagonist equalized after 14 days. So that's why in all the that's why as the discussion has been there since the morning by Amin Joshi sir and also by Kumar sir, that initially the response rate is required, so that time it can be antagonist has reduced, so that within 14 days the testosterone levels are reduced, and after that both of them can be used, but agonists like gosling gives the advantage of giving 3 monthly doses and ease of administration. So that is a good strategy. And also the faster PSA response with LH antagonists have been seen. And the injection site reaction, as I was told previously, it is very less with Degrelix with gosling compared to Degrelix. And one more point is the cardiovascular safety. So cardiovascular safety were also many trials have been done, particularly the pronounced trial, in which the main point was the say cardiovascular safety. So in the clinical perspective, the relative safety of both events controversial, and none of the study has shown differently that one or the other causes more cardiovascular effects. So pronounced study provides a model for collaboration, and in the light of improved cancer survivorship, as Kumar sir told that the patients in the where sometimes they're living up to 7 years. So that is important to see that the patients are not having increased risk of cardiovascular events. So as Amit Joshi sir had put in the panel discussion, that the main point of contention of cardiac safety is that the patients who are already at risk factors for cardiovascular morbidity, in those patients, the meta-analysis have shown that uh, the degradients they have a less chances of uh, 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 causing cardiovascular increased extra comorbidity. But in patients who don't have any risk factors, in those cases, there is no specific implications that the antagonists are more better in compared to cardiovascular safety. So the interpretations that we know that Degras achieves rapid achievement of castrate levels, and now we have Gosling has also been used for more than 3 decades, although not in combination in all the settings. And so there are different indications for the use of both, and both have a role, and both can be combined, as we have shown that initial use of undiagnosed for agonists to lead to better results. So LHRH antagonist and agonists form the widely used form of ADT and are considered first-line therapy due to their ability to provide durable testosterone suppression, effective of several months, with a well-tolerated injection system, and Gostin is a widely used injection with the various advantages I've shown to you in the various slides. And there is, although useful in the initial setting, has its challenges like injection site reaction and inconvenient formulation. And now with the we have better real world data, and so this the benefit of advanced cardiac safety both can be used in their respective settings. Thank you.
Thank you, Dr. Bipinesh. With this, we come to the end of today's session. Now, to give away the momentum, I would like to request our chairperson, Dr. C. Mishra sir, to felicitate Dr. Abhishek Sharma. I'd like to request Dr. Akhil Kapoor, sir, to felicitate Dr. C. Mishra sir. Please do the honors. And Dr. Paramita Paul, ma'am. With this, we now come to end of this session, but there is so much more to come. So I request you all to please join for the faculty dinner and musical program at Hotel Madhuban. That's from 8 p.m. Have a lovely evening ahead. Thank you so much, everyone. Please join us tomorrow also from 9 a.m. in the same venue. We're looking forward for this.